Chronic or overuse shoulder conditions. Chronic or overuse shoulder conditions include glenohumeral joint instability, shoulder impingement syndrome, bicipital tendinitis, thoracic outlet syndrome, and scapular winging.
Shoulder instability means that the shoulder joint is too loose and is able to slide around too much in the socket. In some cases, the unstable shoulder actually slips out of the socket. If the shoulder slips completely out of the socket, it can become dislocated. If not treated, instability can lead to arthritis of the shoulder. Shoulder instability often follows an injury that causes the shoulder to dislocate. This injury is usually fairly significant and the shoulder must be reduced. To reduce the shoulder means it must be manually put back into the socket. The shoulder may seem to return to normal, but the joint often remains unstable. The ligaments that hold the shoulder in the socket, along with the labrum, may have become stretched or torn. This makes them too loose to keep the shoulder in the socket when it moves in certain positions. An unstable shoulder can result in repeated episodes of dislocations, even during normal activities, such as sleeping. Instability can also follow less severe shoulder injuries. Common signs and symptoms include chronic popping or clicking, chronic pain, and they may develop more problems such as shoulder impingement syndrome. Management can either be conservative or surgical depending on the amount of joint instability that is associated with the injury. Rotator cuff strengthening exercises can also assist with stabilizing the shoulder joint. There are two types of flexibility. Hyperflexibility is different than traumatic instability. Joint hypermobility means that some or all of the person's joints have an unusually large range of movement. People with hypermobile joints are particularly supple and able to move their limbs into positions that others would find impossible. Joint hypermobility is what some people refer to as having loose joints or being double jointed. In some cases, traumatic instability can happen without a previous dislocation. People who do repetitive motions may gradually stretch out a joint capsule. This is especially common in athletes such as baseball pitchers, volleyball players, and swimmers. Shoulder impingement syndrome is a common cause of shoulder pain. It occurs when there is an impingement or pinching of the tendons or bursa in the shoulder from the bones of the shoulder. Overhead activities of the shoulder, especially repetitive activity, is a risk factor for shoulder impingement syndrome. Examples include painting, lifting, swimming, tennis, and other overhead sports. Other risk factors include bone and joint abnormalities. With impingement syndrome, pain is persistent and affects everyday activities. Motions such as reaching up behind the back or reaching over the head to put on a coat or blouse, for example, may cause pain. Over time, impingement syndrome can lead to inflammation of the rotator cuff tendons or the bursa. If not treated appropriately, the rotator cuff tendons can start to thin and tear. Primary impingement is due to mechanical compression due to abnormalities in the structure of the joint. These abnormalities could include acromion shapes, either normal versus hooked, thickened tendons, enlarged bursa, or abnormal posture. Secondary impingement is due to shoulder instability and rotator cuff weakness, not a structural issue. The typical signs and symptoms of impingement syndrome include difficulty reaching up behind the back. Pain with overhead use of the arm is common, especially in what's called the painful arc. The typical signs and symptoms of impingement syndrome include difficulty reaching up behind the back, pain with overhead use of the arm, which is commonly referred to as painful arc, and weakness of shoulder muscles. If tendons are injured for a long period of time, the tendon can actually tear in two, resulting in a rotator cuff tear. This causes significant weakness and may make it difficult for the person to elevate his or her arm. Some people can have a rupture in their bicep muscle as a part of this continuing impingement process. The management of shoulder impingement syndromes include restoration of normal biomechanical movement, possible surgery to remove an abnormally shaped acromion process, rotator cuff strengthening exercises, price, and NSAIDs. Biceps tendon, tendonitis, tendinopathy, tendinosis, tenosynovitis are all common terms that describe pain or injury to one of your shoulder's bicep tendons. Bicep tendinopathy is the umbrella term for bicep injuries that include biceps tendonitis, tendinosis, tenosynovitis, and rupture of the biceps tendon. Tendinitis is from an inflamed tendon. Tendinosis is a non-inflamed degenerative tendon. Tenosynovitis is inflammation of the tendon sheath, and a rupture of the bicep tendon is typically secondary to a general degeneration or tear. Biceps tendinopathy is rarely seen in isolation. It is caused by overuse, tendon impingement, shoulder joint instability, or trauma. Therefore, it coexists with a lot of other pathologies of the shoulder, including rotator cuff impingement syndrome, rotator cuff tears, labral tears, slap lesions, and shoulder instability. It is common in sports that involve throwing, swimmers, gymnasts, and some contact sports. Occupations that involve overhead shoulder work or heavy lifting are at risk as well. Biceps tendinitis and tendinopathy sufferers will commonly report pain in the region of the anterior shoulder located over the bicipital groove, occasionally with radiating pain down to the elbow. Overhead activities usually reproduce pain, especially in those positions that combine abduction and external rotation. Examples are cocking to throw. The pain is often aggravated by shoulder flexion, forearm supination, or elbow flexion. Some patients describe muscle weakness and clicking or snapping with shoulder movements. The symptoms are typically alleviated by rest and ice. Thoracic outlet syndrome, or TOS, is a syndrome involving compression at the thoracic inlet, which is clinically known as the superior thoracic outlet, resulting from excessive pressure placed on a neurovascular bundle between the anterior scalene or middle scalene muscles. It can affect one or more of the nerves that innervate the upper limb and/or the blood vessels as they pass between the chest and the upper extremity, specifically at the brachial plexus, the subclavian artery, and rarely the subclavian vein. Thoracic outlet syndrome may result from a positional cause, for example, by abnormal compression of the clavicle or collarbone and the shoulder girdle on arm movement. There are also several static forms caused by abnormalities, enlargements, or spasms of the various muscles surrounding the arteries, veins, and/or the brachial plexus, a fixation of the first rib, or a cervical rib. The most common cause of thoracic outlet syndrome includes a physical trauma from a car accident, repetitive strain injury from a job such as a frequent non-ergonomic use of a keyboard, sports-related activities, and anatomical defects such as having an extra rib. An extra incomplete rib is present in approximately less than 0.2% of the population. Painful thoracic outlet syndrome can be attributed to one or more of the following factors: congenital abnormalities, including a cervical rib, prolonged transverse processes, and muscular abnormalities or fibrous connective tissue abnormalities. Trauma like whiplash or repetitive strain is frequently implicated. Thoracic outlet syndrome affects mainly the upper limbs, with signs and symptoms manifesting in the shoulder, neck, arms, and hands. Pain can be present on an intermediate or permanent basis. It can be sharp, stabbing, burning, or aching. Thoracic outlet syndrome can involve only part of the hand, as in the fourth or fifth finger only, all of the hand, or the inner aspect of the forearm and arm. Pain can also exhibit on the side of the neck, the pectoral area below the clavicle, the armpit or axillary area, and the upper back. Discoloration of the hands, one hand being colder than the other, weakness of the hand and arm muscles, and tingling are commonly present. Stretching, acupuncture, chiropractic adjustments, and occupational or physical therapy are common non-invasive approaches used in the treatment of thoracic outlet syndrome. It is vital to immediately refer patients to get an assessment of the vascular involvement to determine proper therapy. A winging scapula is a common symptom of another condition, rather than an injury itself. It is where the shoulder blade protrudes out on the back rather than laying flat against the back of the chest wall. Patients can complain of shoulder blade pain with pressure on the scapula from a chair when sitting. If caused by an injury resulting in nerve damage, the patient may have limited shoulder elevation as well as shoulder blade pain. A winging scapula is also a quite common dysfunction of the shoulder as it is associated with poor posture. It can also be associated with damage or contusion to the long thoracic nerve of the shoulder and/or weakness in the serratus anterior muscle. If the long thoracic nerve is damaged or bruised, it can cause paralysis of the serratus anterior muscle and winging of the scapula or shoulder blade. Damage to the nerve can be caused by a contusion or by a blunt trauma to the shoulder, traction of the neck, and can also follow sometimes a viral illness. A full rehabilitation and strengthening program consisting of winging scapular exercises as well as a range of other exercises for the shoulder is important. The most important muscle to strengthen is the serratus anterior muscle, which holds the shoulder blade in place.